during ultrasound, there was an incidental pancreatic cystic lesion, which was investigated by EUS. And during that, we find one cystic lesion in the genu of pancreas, which was about 13 into 10 mm, and another lesion in the body. We took FNA from both of them, and the report came as neuroendocrine tumor. One is solid, another is cystic. We also worked him with a DOTA scan, and you can see on the right panel, there are two lesions lighting up without any lesions elsewhere in the body. So these are two pancreatic neuroendocrine tumors, one of which is cystic. And the plan is to do an RFA. Since the proximal lesion towards the head is close to the PD, we also did a pancreatic stenting as a policy. If the duct is very close, 2 millimeters or less, we place a PD stent up front a day or two before. So this stent was placed 2 days back, and now he is for RFA. We've also given him indomethacin suppository as a precaution for post-RFA pancreatitis apart from IV fluids. Experience of surgery versus RFA for insulinoma patients. And we found that RFA is quite effective and a sustained benefit. The PD is just below the stent inside. It's quite close to it. And the other lesion is in the body. As I pull back, we can show that. So for solid lesions, we pass the RFA device and do the RF ablation just like an FNA needle mechanism. But for cystic lesion, we have to have a little different method of ablating. We first aspirate the fluid out, so the cyst collapses and the wall comes in the center, and then it works like we like doing RFA of a solid lesion. Yeah, that's okay. Okay. Aspirate, please. Then we'll be boiling the fluid and not touching the wall. So we want to remove as much fluid as we can, so that both the walls, all walls collapse in the center, and then we can target like a solid lesion.